Ever had that, that burning, almost gnawing feeling? Upper stomach just won't quit.
Yeah, that kind of persistent discomfort.
Right. And you think, oh, it's just indigestion. Maybe grab an antacid. But sometimes, well, it whispers it might be something more, something deeper.
Like an actual sore inside you.
Exactly. Today, we're doing a deep dive into peptic ulcer disease, PUD for short. We've got a great stack of sources here, medical research, clinical notes, the works. And our goal is really to give you a shortcut, to get what peptic ulcers are, why they happen, what they feel like, and crucially, how doctors figure them out and treat them.
Peeling back the layers, basically.
Yeah, get well-informed with some surprising clarity, hopefully.
And this is important because there are a lot of misconceptions out there about ulcers. We'll separate that from the science.
Sure.
Help you understand that, well, that delicate balance in our digestive system, it's easily thrown off.
Okay, let's start right there then. What exactly is peptic ulcer disease?
Fundamentally, at its simplest, it's about open sores, ulcers, developing in the lining of your digestive tract.
So not just irritation, but actual breaks.
Precisely. Little erosions, like craters, you could almost say.
And they tend to pop up in specific spots.
They do, yeah. The most common places are the stomach itself, that's a gastric ulcer.
Okay.
Or the duodenum. It's
Yeah.
the very first bit of your small intestine, right after the stomach.
Right.
And actually duodenal ulcers, they're generally more common than the stomach ones.
Interesting. Anywhere else?
Less often, you might see them in the lower esophagus, an esophageal ulcer. And in specific cases, maybe after stomach surgery, they can form a bit lower down in the jejunum, called a marginal ulcer.
So it's all about that protective lining getting breached somehow. What's doing the breaching?
Fundamentally, yes. It happens when that lining, which is normally pretty tough, gets eroded.
By what?
By the stomach's own powerful digestive juices, specifically gastric acid and an enzyme called pepsin.
Ah, pepsin.
Yeah, pepsin breaks down protein, and the acid makes it work even better. So it's like a constant chemical attack on the lining if the defenses are down.
Okay, so the body has defenses, but something knocks them out or just overpowers them. What are the big things? What are the major causes our sources point to?
Right, this is key. There are two main players that account for the vast majority of cases. Number one, a bacterial infection, H. pylori.
Helicobacter pylori, I've heard of that.
You probably have. It's incredibly common. We're talking like 70 to 80% of gastric ulcers.
Wow.
And even higher for duodenal ulcers, maybe around 90%.
90%. So most ulcers are caused by a bug.
Yeah.
How does a bacterium do that?
It's quite clever, actually, in a nasty way. H. pylori weakens the stomach's natural defenses. It produces this enzyme, urease, which neutralizes stomach acid right around the bacterium, letting it survive. But crucially, it also releases toxins that directly damage the mucosal cells.
Creating weak spots.
Exactly. Weak spots for the acid and pepsin to then attack.
Okay, so H. pylori is huge. What's the other major cause?
The second one might surprise you. It's the regular use of NSAIDs.
Non-steroidal anti-inflammatory drugs. You mean like aspirin, ibuprofen?
Precisely. Aspirin, ibuprofen, naproxen, diclofenac, those everyday painkillers.
Wait, how can painkillers cause ulcers? They just stop pain, right?
They do, but they have a side effect. See, NSAIDs work by blocking certain enzymes involved in inflammation. But in doing that, they also block the production of something called prostaglandins.
Prostaglandins. Okay, why are they important?
They're vital for stomach protection. Prostaglandins tell your stomach lining to produce more protective mucus and bicarbonate that neutralizes acid. They also keep blood flowing well to the lining, which helps with repair.
Ah, so NSAIDs reduce those protective prostaglandins.
Exactly. Less prostaglandin means less mucus, less bicarbonate, weaker defenses. The lining becomes much more vulnerable to acid damage.
So it's not just bacteria, it's also potentially the pills you take for a headache. That's quite something.
It really is. Those are the big two. But there are other, less common, but still significant major causes.
Like what?
Things called hypersecretory conditions.
Yeah.
Basically situations where your stomach just makes way too much acid.
Okay.
The classic example is Zollinger-Ellison syndrome. It's often caused by a tumor, a gastrinoma, that pumps out loads of a hormone called gastrin. And gastrin just tells the stomach,
Make acid. Constant acid production.
Right. Also, high calcium levels in the blood, hypercalcemia, can sometimes stimulate gastrin release too.
So H. pylori, NSAIDs, and these rare acid overload conditions.
Yeah.
What else makes someone more likely to get an ulcer? Any other risk factors?
Oh, definitely. Several other things can tip the balance. Smoking is a big one.
How does smoking affect it?
It seems to delay ulcer healing, and it might also increase acid secretion. Not good.
Right.
Alcohol is another one. It directly irritates the stomach lining
Yeah.
and can also ramp up acid production.
Okay, makes sense. What about stress? Everyone blames stress for everything.
Yeah, and it's a bit nuanced here. Everyday psychological stress. It can definitely make symptoms worse if you have an ulcer. But the kind of stress strongly linked to causing ulcers is usually major physiological stress.
Like physical stress on the body.
Exactly. Severe illness, major surgery, serious injuries. There are specific types, like Cushing's ulcer linked to brain injuries, or Curling's ulcer seen after severe burns. That's profound physical trauma impacting the body's defenses.
That's a really important distinction. Physiological versus everyday stress.
It is. Then you've got genetic factors. Having a family history can increase your risk. And diet, things like spicy foods.
Yeah, people always say avoid spicy food.
The evidence is pretty controversial there. They don't seem to be a primary cause. They might aggravate symptoms for some people who already have an ulcer, but they don't generally create one.
Got it. So you mentioned this balance earlier. It sounds like PU is really about a fight inside us. Aggressive forces versus defenses.
That's a great way to put it. It really is an imbalance. On the attack, the aggressive factors, you have gastric acid and pepsin, obviously.
Right.
H. pylori infection, NSAIDs, and sometimes even bile reflux bile flowing back from the small intestine into the stomach.
Oh, okay.
Yeah, it's irritating. Then on the other side, you have your body's defenses.
The good guys.
The good guys.
Uh.
The thick mucus bicarbonate barrier that's like a physical and chemical shield. Good blood flow to the lining brings nutrients, washes away bad stuff.
Uh-huh.
Those prostaglandins we talked about, PGE specifically. And the lining cells themselves, the epithelium, they can regenerate really quickly.
So when the attack is stronger than the defense,
Boom, you get an ulcer. The aggressive factors win that battle, at least temporarily.
does this imbalance also explain why some ulcers are in the stomach and others are in the duodenum?
Yes, exactly. It helps make that distinction clear. Duodenal ulcers often happen in a setting of high acid secretion, usually plus H. pylori. Think, too much attack. Gastric ulcers, on the other hand, are frequently about weakened defense. The protective layer is compromised, often by H. pylori or NSAIDs, even if the acid levels aren't sky high. Think, defenses down.
That's a really helpful way to think about it. So shifting gears a bit,
Yeah.
what does this actually feel like for someone? How does an ulcer make itself known?
The classic symptom, the one people usually talk about, is that epigastric burning pain.
Epigastric, meaning upper middle abdomen, below the ribs.
Correct. Right there. But here's where it gets interesting, and it can be a clue. The pattern of the pain often differs between duodenal and gastric ulcers.
Oh, how so?
With a duodenal ulcer, the pain typically kicks in, say, 2 to 3 hours after you eat, when the stomach is emptied.
Okay.
And here's the really characteristic part. It's often relieved by eating again or by taking antacids.
Eating makes it better. That seems odd.
It does, but food can buffer the acid temporarily or close the pylorus, the valve leaving the stomach. Also, waking up with pain in the middle of the night. Very common with duodenal ulcers.
Wow. Okay, so what about gastric ulcers then? Opposite.
Pretty much the opposite, yeah. With a gastric ulcer, pain often gets worse when you eat
Why?
because eating stimulates your stomach to produce more acid to digest the food, and that acid then directly irritates the ulcer in the stomach lining.
Makes sense. Are there other symptoms besides the pain?
Sure, things like heartburn, bloating, maybe some nausea. They're less specific. Could be other things too, but they often accompany ulcers.
You mentioned weight changes earlier too.
Right. People with gastric ulcers might lose weight because eating hurts, so they avoid it. But someone with a duodenal ulcer might actually gain weight because they're eating frequently to relieve the pain.
Fascinating differences. Now, beyond these typical symptoms, you mentioned alarm symptoms. These sound serious.
They are. These are red flags. Signs of potential serious complications that need immediate medical attention. No waiting around.
Okay, what are they?
First, hematemesis. That's vomiting blood. It could be bright red blood, or it might look dark, like coffee grounds if the blood's been sitting in the stomach acid. Either way, it means upper GI bleeding.
Got it. Vomiting blood equals emergency. What else?
Melena. That's Melena. It refers to black, tarry, really foul-smelling stools.
Black stools.
Yeah, it's the appearance of digested blood in the stool. Again, sign of bleeding somewhere in the upper digestive tract. Needs checking out fast.
Okay. Bleeding signs? What else?
Sudden, really severe abdominal pain, often described as sharp, like a knife. If that happens, especially with a rigid, hard abdomen when someone touches it, that's a classic sign of perforation. The ulcer is eaten right through the wall. Contents are leaking into the abdomen. That's a surgical emergency.
Perforation. Wow.
Yeah.
Okay. Anything else?
Yes, one more main one. Early satiety. Feeling full after just a tiny amount of food, especially if it comes with persistent vomiting.
Feeling full quickly and vomiting.
That could point to gastric outlet obstruction. Basically, swelling or scarring from the ulcer is blocking food from leaving the stomach properly.
Okay, those are definitely alarm bells. So if someone has persistent pain, or especially any of those alarm symptoms, how do doctors figure out if it's an ulcer? How do they diagnose it?
There are a few approaches, starting often with non-invasive tests, especially if we suspect H. pylori.
Like what?
The urea breath test is very good, often considered the gold standard for detecting an active infection.
How does that work?
You drink a liquid containing urea with a special carbon isotope. If H. pylori is there, its urease enzyme breaks down the urea, releasing labeled carbon dioxide, which you breathe out, and we measure it.
Clever.
Yeah. There's also a stool antigen test. Looks for H. pylori proteins in a stool sample. Also very good for active infection.
Okay. What about blood tests for H. pylori?
This is a really important point. The antibody blood test, serology. It can only tell you if you've been exposed to H. pylori in the past.
Not if you have it now.
Exactly. The antibodies can stick around for years even after the infection is gone. So it's not useful for diagnosing a current infection or seeing if treatment worked. Big limitation.
That's a crucial distinction. Good to know. Other non-invasive tests.
We might do a CBC, a complete blood count, to check for anemia if we suspect bleeding. And if Zollinger-Ellison syndrome is on the radar, we'd check serum gastrin levels.
Right. But to actually see the ulcer, you need something more direct.
Yes. For a definitive look, the main test is an EGD, esophagogastroduodenoscopy.
It's a poke test.
The scope test, exactly. A thin, flexible tube with a camera goes down the throat. Allows the doctor to directly visualize the lining of the esophagus, stomach, and duodenum.
So they can see the ulcer.
See it, assess its size, location, and crucially, take biopsies, little tissue samples.
Why are biopsies so important?
Especially for gastric ulcers, it's vital to rule out cancer. Some stomach ulcers can actually be malignant. Biopsy is the only way to know for sure.
Okay. Very important.
Plus, during the ETD, they can do a quick test on a biopsy sample for H. pylori right then and there. It's called a rapid urease test or CLO test.
Gotcha. Any role for imaging like X-rays or CT scans?
Usually only if we suspect complications. An upright chest X-ray can show free air under the diaphragm if there's a perforation, this air leaking out.
Okay.
And a CT scan of the abdomen might be used for a better look at complications like perforation or maybe an abscess.
Right. So once it's diagnosed, confirmed it's an ulcer, what's the plan? How do you heal it?
Treatment is usually multi-layered. Starts with general measures.
Like cake.
Well, if NSAIDs are the culprit, stop them if at all possible. That's number one.
What if someone needs an NSAID for, say, arthritis?
Sometimes we might switch to a different type, a KOX2 inhibitor like celecoxib, which is generally a bit easier on the stomach lining, but ideally stop them if you can.
Okay. What else?
Smoking cessation. Quitting smoking is huge for healing. Limiting alcohol too. And diet, again, avoiding specific trigger foods like spicy things or caffeine if they cause symptoms for you.
Okay.
It's more about symptom control than healing the ulcer itself.
Makes sense. Then medications.
Absolutely. Medications are key. The main goal is acid suppression.
Reducing stomach acid.
Right. And the go-to drugs for that are PPIs, proton pump inhibitors.
Like omeprazole, pantoprazole.
Oh, exactly. Omeprazole, pantoprazole, esomeprazole, lansoprazole. They are very effective at shutting down the acid pumps in the stomach. First-line treatment, usually.
What about older drugs like ranitidine or famotidine?
Those are H blockers. They also reduce acid, but they're generally less powerful than PPIs. So more of a second-line option these days or for milder symptoms.
Okay, PPIs are the main acid reducers. What else?
If H. pylori is present, and remember, it often is then, eradication is essential. You have to get rid of the bacteria.
How do you do that?
Standard treatment is usually triple therapy. It's a combination for typically 14 days.
Triple meaning 3 drugs.
Yes. A PPI plus 2 antibiotics. Usually clarithromycin and either amoxicillin or metronidazole if the person is allergic to penicillin.
14 days of 3 pills.
Correct. Sometimes, if there's concern about antibiotic resistance or if triple therapy doesn't work, we might use quadruple therapy.
4 drugs.
Yep. Usually a PPI, bismuth, like pepto-bismol, but prescription strength, and 2 different antibiotics, metronidazole and tetracycline.
Okay, so kill the bug if it's there. Anything else?
There are also mucosal protectants. Sucralfate is one. It kind of forms a sticky paste that coats the ulcer crater, protecting it from acid.
Like a Band-Aid on the inside.
Sort of, yeah. And misoprostol, that's a synthetic prostaglandin. It can be particularly helpful for preventing or treating NSAA-induced ulcers because it replaces those protective prostaglandins the NSAIDs deplete.
Right, replacing what the NSAIDs took away. Now, what if things get really bad? Those complications you mentioned earlier, bleeding, perforation, how are they treated?
That requires more urgent, often invasive intervention. For a bleeding ulcer, treatment is usually done during that EGD scope.
Ow!
The endoscopist can use various tools, inject medications to stop bleeding, use heat, cautery to seal vessels, or apply tiny clips to clamp off bleeders. Afterwards, high-dose IV PPIs are usually given.
Okay, and perforation,
Yeah.
the hole.
That's almost always emergency surgery. The surgeon needs to close the hole, usually by sewing it up, and often they reinforce it with what's called an omental patch, using a piece of fatty tissue from the abdomen to plug the leak.
Wow, sounds serious.
It is. And for gastric outlet obstruction, the blockage. Sometimes it can be stretched open with a balloon during endoscopy, but if that doesn't work or the blockage is too severe, surgery might be needed to bypass it.
So, looking at the bigger picture, these complications sound pretty severe. Untreated PUD isn't trivial.
Not at all. The stakes are high. Hemorrhage, the bleeding is the most common complication, can be life-threatening.
Right.
Perforation, leading to peritonitis, that widespread abdominal infection and sepsis, also potentially fatal.
And you mentioned penetration.
Yeah, that's where the ulcer doesn't go right through into the abdominal cavity, but erodes into a nearby organ, like the pancreas. Causes intense pain and inflammation there.
Ouch.
Gastric outlet obstruction can lead to malnutrition and dehydration from vomiting. And here's a really crucial long-term risk we need to emphasize.
What's that?
The malignancy risk. Chronic H. pylori infection, particularly leading to gastric ulcers, significantly increases the risk of developing gastric cancer later on.
So H. pylori isn't just about ulcers, it's linked to stomach cancer too.
A definite link. That's why eradicating it is so important, not just for ulcer healing, but potentially for cancer prevention too.
That's sobering. Okay, so given all these potential problems, how do we prevent ulcers or these complications? What are the strategies?
Prevention really circles back to the causes. H. pylori screening and treatment, especially in people with symptoms, or maybe those with a strong family history of ulcers or stomach cancer.
Be proactive about H. pylori.
Exactly. And for people who absolutely must take NSAID long-term, using the lowest effective dose for the shortest time is key. And often, doctors will prescribe a PPI alongside the NSAID for protection. That's called PPI prophylaxis.
Taking a stomach protector with the NSAID.
Right. And in hospitals, especially in the ICU, patients who are critically ill often get stress ulcer prophylaxis, usually with a PPI or sometimes an HRO blocker, to prevent those severe physiological stress ulcers from developing.
Okay, so there are definite preventative steps.
There are. It's about managing the risks.
Well, this has been incredibly comprehensive. We've gone from that tiny H. pylori bacterium and the effects of common painkillers through the internal battle of acid versus defense, the specific symptoms, how doctors diagnose it, right up to treatments and preventing serious issues. I think you really do have a solid handle on PUD now.
Absolutely. It's a condition that, yeah, it can be serious, it can have major complications. But the key takeaway is that understanding the causes, recognizing the signs, knowing the diagnostic tools and the effective treatments we have now, it makes a huge difference. It empowers people to seek help early and manage the condition effectively. Better outcomes, better quality of life.
Definitely.
And, thinking about that H. pylori link, it does raise a fascinating question for the future. Given that clear connection between chronic H. pylori and gastric cancer risk, just imagine. How might more widespread, more proactive screening and eradication of H. pylori truly change the landscape of gastric cancer globally in the decades to come? It's something to think about.
That is a powerful thought. A potential future with much less stomach cancer, perhaps. Thank you for joining us on this deep dive today. Keep exploring, keep asking questions, and stay informed.